Well, it's a pleasure to be here, and thank you very much, Andy, and to the whole team for organizing this. It was really impressive to hear Joy's sort of tour de force explanation about trauma-informed care, and I know I learned a lot. She and I look forward tomorrow to, as she mentioned, having a breakout session. But it's my pleasure to talk to you about this concept called person-centered care. And as Andy mentioned, we're going to have quite the panel in a few minutes. The way this is going to work is I'm going to talk for about 10 or 15 minutes just to set the stage about more of the nerdy definitions of what person-centered care is. Um, and then we'll go on to the panelists so that what you'll hear is a process of people thinking out loud, almost like an MDT meeting, um, uh, with a focus on person-centered care. One thing I want to tell everybody is we're not coming in thinking we know how to do person-centered care in MDTs. We are coming in and thinking we're paying attention to it. We think it's important. We'll explain why in a moment, although I'm sure you're already aware of a lot of that. So we're not saying we have it right. We're going to be going through the difficult processes here, and because we're a real world team working in Los Angeles County. So we're going to talk about kind of the messiness and when it, not only when it does work, but when it doesn't work, and think it through. We want you to interrupt us as we're going. We're all on board with that. So we have great moderators who are kind of watching the chat column, and we've really said to them, feel free to interrupt as we're talking, whether it's me in the intro or whether it's with the panelists, so that you're involved and that we're really getting to the heart of the matter. No doubt you'll have some excellent ideas that we haven't thought of, and some questions that I think will be thought-provoking. So this doesn't have to all be agreeable. As with real-life MDTs, it's going to be messy, and that's okay, because that's how we achieve the best that we can do on behalf of the people that we're serving. So with that, I'm going to share screen and move on to the slides. And because I can't see the rest of the screen now, just the slides, if somebody can just give me a verbal yes that you can see the opening slide, I would appreciate it.
We cannot see the slide.
Okay. Glad I checked. Let's try this again.
There we go.
Thank you.
Yes.
So these are the players, as Andy mentioned, and since this is not a cognitive test, we're not going to make you remember all these people, but as the panel starts, each person will take a moment to introduce themselves, not with Andy said, but more with why they're part of the MDT and the person-centered part of things. Okay, person-centered care. It's a term that gets thrown around a lot, kind of like trauma-informed care. And sometimes we don't realize that there is, if not science behind it, a lot of communal conversation about it, and that it really has meaning. It isn't just a feel-good phrase, but it has actual actions that can be taken in relationship to the practice of person-centered care. So it really involves understanding what a person's values and preferences are. And that means sometimes we have to elicit that from somebody. They're not just going to come out and say it. So we need to have techniques for how we elicit this, and that we then use what we learn to guide their care to support the goals of, depending on your perspective, the older adult, the client, the victim, et cetera, but the person we're there to serve. And that it's a collaborative process, which may involve not only supported decision making, which gets a lot of conversation, not only shared decision making, but supported decision making as well. This is a definition that came from an expert panel and was published in the American Geriatric Society. And the idea is that person-centered care means that we elicit the values and preferences, use them to guide aspects of their health care, and it needs to support realistic health and life goals, because, you know, sometimes we get into, well, sometimes what somebody wants simply isn't possible, and we understand that. Even though many of the people on this video actually do the impossible every day, there's only so far we can go with all that. In order to do this, we have to have this dynamic relationship among individuals. And sometimes it's not just the direct older adult that we're serving or the person with a disability who we're serving, but it might be their loved ones, people who are important to them, and the relevant providers as well. And we then can use that collaboration to inform decision making, as, again, still led by the person that we're there to serve to the greatest extent possible. Believe me, we're going to talk about people with cognitive impairment and some of the difficulties there. But one thing we want to make clear is just because you have a label like a diagnosis of Alzheimer's doesn't mean you no longer have any autonomy or ability to request a person-centered approach. Well, this sounds good, right? Who doesn't want to elicit somebody's values and preferences? But let's face it, sometimes we are in the middle of a very tense situation. And so does that mean that when we're in those situations that we can't even try to figure out a person's values and preferences? And then how do we operationalize it? So what does it take? And the panelists will help us understand this. When you want to talk to somebody and you're in kind of a rather tense situation, how exactly do you start figuring out what their values and preferences are? This is something that comes up for us on a regular basis, and I imagine it would for you as well. What if we think that, hey, person-centered approach sounds really good, but it's going to put this person in danger because what their preference is going to put them in danger, right? I think we've all, and we touched on that a little bit, I think in the Q&A last time, have seen somebody who we feel is in a very unsafe situation, and seemingly the only option is a nursing home, and they would rather stay in a very dangerous situation than go into a nursing home, as an example. Importantly, what is the role of the facilitator of the MDT? I believe we have quite a few facilitators on this call, and you play such an important role, not just in the organization, but really in the culture of the MDT. And part of that culture is whether or not you're going to be person-centered. And what I would really hope for as we discuss this, I'd like for you to think about a few things, which is if by the end of this presentation, you buy into the idea that we can do a little more in terms of person-centeredness, we think this is important and it's worthy. Think about just one small, or maybe two, small incremental changes that you can start in your very next MDT meeting. And perhaps we can put some of those in the chat as we begin to wrap up. All right. Well, with that in background, I thought I would tell you a little bit about how we operationalize it. But I'll tell you what, before I get to our MOU, let me just pause and ask, I don't know if Shelley's still kind of running the joint or Talitha, are there any questions or comments yet that I ought to address?
This is Talitha, and I'll be your moderator, and I do not see any questions yet.
Okay, don't fall asleep on me out there, everybody. Keep questions and comments coming in. All right. So here's just a little bit about how we roll in our Los Angeles County MDT, which is run by our Department on Aging and Disability. First of all, when we were reconfiguring things with this new department, we created a new purpose statement that's in our MOU that every team member signs. And we put in there that our recommendations, I highlighted in yellow, are intended to not only increase safety, but enhance autonomy and prevent further harm and support greater independence and wellness. So this whole conundrum of promoting autonomy while maximizing safety is always at the fore of what we're doing. And those things are often in tension with each other. These are the members of our MDT who attend regularly. Probably looks pretty familiar to you. And thank you to the fabulous Fabi who helped me put this slide together. You'll meet her a little bit later. but our legal services, along with APS, legal services, and some clinical service providers such as myself and Dr. Bonnie Olson, law enforcement, of course, consumer protection, public guardian, our ombudsman, and then our elder abuse prevention experts from Wise and Healthy Aging, who you'll meet in a moment with Miles. We also have people available on a, for those in medical, a PRN basis or on an as needed basis. So for example, Kaiser Permanente is a large healthcare system that's quite prevalent here in Southern California where we live. So it's not uncommon that we have a client who actually has Kaiser insurance, and we have a very direct contact with Kaiser. The same is true with the regional center and the Office of Inspector General through the Social Security Administration. So they don't come to every meeting, but when we need them, we have very specific contacts of people who are available to make it easier. So don't panic. This is just, I'm going to go through this form in a little more detail in a minute. This is probably familiar to many of you. And I will say we're happy to give this form to anybody who wants it. But this is online, and so it has drop-down boxes. But this is the 2-page intake form when somebody is making referral to our MDT, which is also known as the LA County Center of Excellence. So it's the usual kinds of stuff at the top in terms of names and dates and all that. And as I said, we have drop-down menus to try and make it easier for the person to fill out. We ask for information. So what does it seem like their physical functional status is like and their cognitive status? We ask a little bit about the alleged abuser and what their circumstances might be, whether there are other agencies already involved. And then we ask about the type of abuse, which oftentimes, as you all know, is more than one. And what team members do you, the referrer, think are needed? Oftentimes this changes by the end of the meeting, but it gives us a start. And then there's room for a narrative. But the one key question that we added at the bottom of page 2 is, what are the client's goals and wishes? And you'd be surprised, but this one little thing actually helps remind all of us that we need to know what the goals and wishes are. And it reminds the person who's making the referral that if you haven't asked, you need to ask, because we all would like to know that once you come to the meeting. So we can take a pause. This is the same slide you saw a moment ago about how we want to put this into practice. And we're going to move on to the panel. But first I'm going to, so that we can kind of show you how we operationalize it. But let me first pause and ask if there are any questions or comments that I ought to address now.
Yes, there are a couple of questions that have come in. How would this form be different from an APS intake form? And could submission of this form lead to an APS referral or vice versa?
And we might, I might, if I screw up the answer, then Francisco Wong will chime in for me. But so an APS form is it has very similar information on it, but it also is different than this one. So we want to be clear that there are different processes and different forms. If somebody is making a referral, oftentimes this has already been through APS, and certainly APS is one of the most common referrers to our MDT. Sometimes the police are making the referral, and this is new to APS. Sometimes they've already been in touch with APS, and we know that they're involved as well. So it's a pretty individual situation. The form is online available. That's why the drop-down menus work and can be sent in and they're looked at prior to the meeting.
Is this form virtual or paper?
It's virtual. It's an online form. That's why we can do the drop-down menus. But if somebody wants to do it in paper and fill it out, fine with us.
And
It
is
just
this
makes it a little easier.
intake in place of an APS referral, or is it in collaboration with an APS
It
referral?
does not replace an APS referral. And let's just remember, like, APS gets a gazillion referrals in Los Angeles County, and it's just a small percentage come to our Center of Excellence. But this is a separate form. It's handy if you've done an APS referral, because a lot of that information can just be put right into this.
And one more question. How does your MDT approach, assess, or flag for anosognosia when referring people for evaluating their capacity?
I'm sorry, what was that word?
I believe it's anosognosia. Maybe I'm saying it incorrectly. It's ANOSOGNOSIA.
Uh, Sorry. Let me look that up later, and I'm not sure, or maybe the person who asked the question can explain what they mean and why they're asking that question.
This is a neurological condition that prevents people from recognizing their mental health or neurological deficits.
Oh, agnosia maybe. Yeah, let's talk about that later, because that, I think, is a little off the topic of person-centered care for what we're doing today. But when people, and but it's a common issue, so it's important to bring up. Let me just address it briefly, which is this lack of insight that people have. Like, I don't have a problem, you have a problem, and are absolutely convinced of that. And one thing we know is trying to explain it to them doesn't work. And this is often seen in, for example, financial abuse, where people don't recognize it. So this is where we, kind of referring back to some of Paige Ulry's stuff, also have to look at capacity, and how much of this relates to personality and prior behavior and how they've always viewed things, and how much of this might be something new where they're incapable of understanding, comprehending their situation due to a
Thank you. That's all the questions for the moment.
okay. I was like, any other questions I can't answer for you? Okay, so let's go on to the panel. So here is the first case, and I have to say I cringe every time I say case. It's the term that we certainly use in medicine, I think, in lots of times in training, but we certainly don't want to think of our people as cases. But this is it. This was a person that actually Dr. Olson and I went out with police to go see her. So she's a 38-year-old woman with multiple sclerosis, and she's mostly paralyzed except for use of her right hand. So that means she needs help with all of her activities of daily living. She has a pretty significant medical history, everything from very severe urinary tract infections that are hard to treat with multiple bed sores. Her feet were in horrible shape. Actually, parts of her toes were dying. That's the necrotic feet. Um, she lives with husband slash boyfriend for about 20 years. Um, he's been her caregiver for about 15 years, 3 children. She has one son who now lives in another country with relatives, just because it was so hard to handle all this. We went to the house. It was filthy, infested with cockroaches, sometimes electricity, sometimes not. CPS had been called, but did not feel that they needed to take action. She receives $2,800 a month, including IHSS, and wants to remain home with her children. So I'm actually going to ask Dr. Olson to start this off, and then I'm going to sort of sit back and let the panel take off to kind of talk about how do you approach person-centered care in a situation like this?
Okay, great start, Laura. What I can say, I just want to say, when we got this referral is how horrific the details, the level of filth in the house and the bugs and her physical condition. Just the report to us before going out There was as if there could be no way that we could leave this person in this situation. So there was great urgency and a sense of really distress in the MDT. I was scheduled to go out to see her with the police, and I actually asked Dr. Mosqueda to go along with, because I could see that there was a lot of medical issues going on, and I really wanted to have a medical person with me, so it wasn't just the cognitive, sort of emotional, sort of verbal part of what is her capacity, although that was the first sort of question at hand. But it was really, I wanted to know just how compromised medically she was, if that was possible based on a sort of a bedside assessment. And it was, if anything, more in bad, the home was in worse shape than we ever anticipated. It was really filthy. And when we walked in, I mean, there were bugs crawling over top of her in the bed, on the bed sheets and the blankets and so forth. Yet this woman was able to very clearly articulate to us what her intentions and her wishes were. Now she seemed, and we saw her alone. Husband/boyfriend was in another room or outside the room talking to the law enforcement folks. So not in earshot, he wasn't hearing what we were saying. Yet she was kind of looking over her shoulder, kept like, as if like, I want to make sure he's not hearing me, which often is a sign to us that, uh-oh, she's really concerned that should he hear, then there'll be some retaliation. So that was noted. But her ability to articulate to us what her intentions were and what her concerns were crystal clear. She said that she was aware that her medical condition would make her suitable for nursing home placement, and she knew she would get better care there. So she was aware of that. She also said, though, that her primary concern was that if she went to a nursing home, her children would not be cared for, that she would be abandoned by her boyfriend, husband, and the kids would be left high and dry. And she wasn't willing to do it. She said, I choose this over that alternative, which didn't feel good at all. It really didn't sit well, but that's what we heard, and that's what we reported back to the team when we met in the back within our MDT to talk through next steps. What do we do now? So in terms of capacity, I didn't do any cognitive testing, but I didn't need to. She was very able to talk through and be articulate about what her wishes were. So I think it kind of makes sense, if I may, pass it over to maybe Miles to talk about a little bit who else on the team weighed in and where we landed with this.
Sure. Yeah, happy to do so. Thank you for providing the context around this situation. So I think one, and as I think both of you mentioned, there was an importance to speaking out loud the discomfort we all had as a team in this situation and what seemed to be our limited ability to support the client and the client's family. I think one of my reflections on this particular situation is some of the work we did. By we I mean certain team members, to ask us all, to ask the team to pull the lens back and try to step away from some of the specific intervention ideas that were presented as options. And I'm just going to give an example of one of the ways this came up. So, and I think this really speaks to the value of having an MDT, people of just different expertise and in different fields. But you know, one of the pieces of information that came up was because there were the minor children in the household. Well, how can Child Protective Services play a role in this case? And one of the initial responses was, well, you know, they're not going to remove the children, and because of A, B, and C. You know, essentially because of, you know, the concern was it would cause more trauma to the whole situation. So again, the idea of pulling back the lens and having folks with different expertise to really flesh out, well, that doesn't mean that it ends there. There can be, you know, CPS is really well situated to come in and support the family in other ways besides removing the children. CPS has some of their resources that some of the other MDT members may not have, to provide other supports that are going to reduce harm. So in summary, I think speaking to the broadening of ideas and possibilities that are, you know, following more of a harm reduction model, and I'll stop there for other thoughts.
Thanks, Miles. I think one of the things besides bringing back CPS and asking them to go out again to reevaluate that family and kind of really get a feel for, have things gotten worse? Was there some interventions that they could offer? And they, again, went back out and said, as you just said, you know, that they felt that it was reasonably safe for the kids. They were being fed and going to school, and the youngest was in another country, so safe there. And I think that's when we kind of turned our attention then to, if we can't remedy this basic situation of getting this woman better care, what can we do? So I think the advocate was really the response that made us all at least sleep at night and feel like, okay, there's something going on here. And so the advocate was coming back into the home and actually working then with the husband to try and get him to access additional services and make sure that he was using and spending the money that he was getting for the household, but using it more appropriately and helping him to access resources that would help, you know, sort of keep the sort of the wheels on the bus turning so that it didn't tip over. And I think it also imparted to the husband, you know, there's eyes on this. Do a good job here, as good as you can under the circumstances. And if it were to get worse, we will see this and we'll be able to respond. But just tough place for this to land. I don't know.
Can I just add? Thank you for, yeah. That's such an important part of it, is the ability of the advocate to participate. I think another just like critical component of the advocate response is the time. Right, where many of the team members just don't have the time to really flesh out the possibilities with the client or the family. And it can, you know, it takes time to build trust and rapport in the relationship. And then to say, okay, well, these options don't seem like they're going to be a good fit for you. What else can we think of? You know, what about this? What about, you know, what about that? And collaboratively coming to some other possibilities.
I'm wondering about hearing about some of our other panel members. So for example, like from an APS perspective, does this put an APS worker in a difficult position when you come out and see somebody in this situation and we're like, well, this is where she wants to stay, even though it's really horrible?
For APS, it does, and we always want to make sure that we respect the person's wishes. You know, they have, after they have capacity and they want to stay, or if they want to leave, that's difficult. And many of the times, they ask for our help to place an individual, and we at APS, at least in California, we cannot place an individual in a facility like children's services can. So it definitely does create a difficult situation for our APS workers.
And Fami, I don't know if you recall, was there any, because I wasn't at the team meeting, was there any controversy in the team meeting and that you had to kind of help manage?
I know that different views did come into play between law enforcement and some of the social services that were being provided. I think the biggest role for me in this case was making sure that everybody involved was in communication, just to better serve the client, to make sure that every perspective was taken into account, all factors were considered. So I do remember some challenges in between law enforcement and social services, but I think ultimately everybody worked together to just provide the client with the best outcome for her.
I can add that there was some tension because the law enforcement folks really wanted to arrest this boyfriend, husband, and on grounds of neglect. And you know, I mean, I don't know. It seemed like the discussion sort of focused around, is that going to get this client in a better place? Is this going to result in a better outcome? And I think we all sat there and went, ooh, and then what? Let's say, even if it was possible for him to be arrested, if there was enough grounds for that, then the kids would be taken away because the wife's, you know, our client certainly didn't have any capability of caring for children. And then she could then be placed in a skilled nursing where she'd get care, but the kids would end up in CPS in their custody. So I don't know, Renee, do you want to add anything to, you know, possibility for prosecution on a case like this? It was just, I think we all went, yeah, no, this isn't going to result in a better outcome, really.
So we've had cases similar where the husband was not able to take care of a wife. Say she had fallen, left her on the floor for 5 days. She was refusing to she didn't want him to call for help. He couldn't pick her up. They were kind of locked in this dysfunctional relationship that had gone on for a very long time. And ultimately he was arrested. He was charged. I think that DA, through our recommendation, came to the Center of Excellence, presented the case. Ultimately, it was decided no one really wanted to prosecute the husband, but until something extreme happened to sort of jar that dysfunctional relationship, it made the wife more amenable to having an outside aid come in. She finally accepted her husband wasn't able to do it. And so we ultimately dismissed the charges. So sometimes, you know, we have to take a drastic measure in a completely unsafe, dysfunctional situation to sort of rock worlds, to ultimately get out to the better side where everyone has a happier, healthier life. And if that means arresting him, and I'm not sure there was I mean, he's IHSS, he's getting money to take care of her and she's in such bad shape. But if she's self-neglecting, that's a defense to neglect. So she's going to say, I wouldn't let anyone treat me. I wasn't going to the doctor. So he might have a defense, a very good defense to neglect for her. I agree that there should be, in situations like this, as many eyes on the situation as possible, which means law enforcement could go in and do welfare checks just to make sure on a regular basis. I know we have local prosecutors in the city attorney's office. They sort of have areas within the city of problem places. And so we can put it on a city attorney's radar to watch out for it. Eyes on a situation sometimes gets people to step in line. I think her fear is that just one more thing is going to send this husband or boyfriend, you know, common law, out the door, and then she's really going to be in trouble. So I agree that the way to go is to go to him, bond with him, take some of that IHSS money, give it to somebody else, take that caring piece away from him, and try and figure out a way to re-guide that dynamic, which is super dysfunctional for such a long time. And it's not a healthy environment for those kids. It's not healthy for her, for the husband, for the kids. So I think that's times when law enforcement, we want to go in there like, the bulldozer, the bull in the china shop, and say, we need to knock some sense into some people, make them uncomfortable so we can ultimately get back to the place where they want to be, because we just can't convince them to do this for themselves, to get better when they're all stuck in their own dysfunctions. And so, and it's very frustrating to see a situation like this, knowing, well, can we do something? What can we do? Eyes on is important. Bonding with the husband is important, but she is in a bad way. And so bonding with her is significant as well. She's probably got a lot of guilt and a lot of stuff going on in her life. She might need counseling so she can have someone to talk to about her struggles. There's probably no one she can lean on, not the kids, not him. And so she's trying to manage all that too. So getting therapists in there, and a social worker.
We're getting to all the problem solving on this as well.
Yeah. I mean, but sometimes it takes something severe to get involved. And ultimately what we're going to do is we're going to dismiss people. We're going to make sure people get he gets parenting classes or whatever.
Right. So without getting into that level of specificity, maybe right now, just because I in a moment, I think Dr. Olson has one more thing to say, and then I want to hear from the audience before we move on to our next case. But yeah, I really appreciate what you're saying there, Renee. Yeah, sorry, go ahead, Bonnie.
Sure, and I think we're all aligned here. It's just, where in this process are we today? And I think where we landed as a team in the Center of Excellence was in saying, we're not going to push prosecution now. We're not going to take the kids away now. We're not going to do this. We're going to have the advocate go in. And the goal was really to try and see if we could get him, the husband, to agree to outside caregiving. And we don't know yet. We're sort of in that process. It may end up with, the big gun happening, as Renee described, but not yet. And so we're giving it some time, but there are eyes on it. And the law enforcement did say, we'll back off, we'll give this some room, but we're hoping for better stability in the system. It's not comfortable, but it's where we landed today, just right now.
Okay, Miles, it looks like you wanted to say something.
Yeah, I hope this doesn't take away too much from that messaging, because I think that's still important. And we don't, as this was happening in real time, we don't know, where the case is going to go. But I do have a little bit of an update that's kind of fresh off the press that I think is helpful for us in how we're thinking about this, because we needed to be patient, right? And say, we're gonna see what happens with the work of the advocate. But the latest update from the advocate for this situation is that the house was is in much better shape than it had been, and that the client is receiving home health services now from their medical provider. So there's something here at the end of the story that looks like, some of these efforts really made a difference.
Yeah, no doubt it was a team effort. And I just want to remind us all, from the person-centered perspective, this is what this person really wanted, was she recognized that she wasn't living in a good environment. So let me do a pause here and see if people in the audience have questions or comments or concerns that would be good to hear about now before we move on to another case, because we're not wed to having to get through the cases.
We have some thoughts and some questions. I think that I really appreciate this format because like we can see the grappling and the audience is grappling with you. Have you tried this? Have you tried that? So some of the questions were like, is there a DV advocate involved to get the DV perspective? If you want to address that, then I can jump into some of the other thoughts.
Yes, so we don't, I don't think we have a specific DV advocate on this team. I know there are teams that have that, but we certainly have knowledgeable people available when needed. But you're right, I think that could have been a very good perspective to hear in this particular case, so I appreciate that. I also just want to point out, if we just step back and look at what all of us are doing, we're immediately moving toward problem solving. And that's where our brains go, which is understandable. And I would urge us to either simultaneously or maybe just take a quick pause before we go to problem solving and step back and take in the bigger picture as well. And I think actually talking about DV is a good example of taking in the bigger picture as well. I'm sorry, I should have let the panelists handle this more. What do you all have to say related to a DV specialist in this person-centered approach with this particular case?
We have, our advocates are DV advocates. I have 1.5 actually. And oftentimes they do sit in on these meetings. I don't know if either advocate was on for this particular meeting to weigh in. I guess I think we know behind the scenes that there's potentially this intimidation going on. But it's not completely spelled out in these facts. And so I guess it would depend on how forthcoming she would be. If we had found out from the Center of Excellence advocate that DV was an issue, then we could certainly have sent one of our advocates in as well. Maybe had an introduction, a warm handoff kind of thing.
That's great. I have another thought here.
I'll just say one other thing, Bonnie, you could nod if you agree. As I recall, we asked her specifically when we were alone with her, and weren't hearing that. Yes, go ahead, Talitha.
Sometimes respecting a client's wishes to remain in a terrible condition can appear to the public or to other member agencies, potentially even that APS or the team, they don't care and they're doing anything. And such complex issues and wanting to make your services so person-centered.
Who wants to take that one?
I often feel that, we see, neighbors, you hear people saying, why didn't you do something? You should have, or you do something, and they say, why did you do it? And I think in this work, pretty quickly, you learn that this isn't being tried in a court of public opinion. It's really about what's going to be right for the client and going to balance that safety and autonomy issue as best we can. And sometimes that's going to make other people unhappy. I'll try and explain, but often it doesn't land well. And I just kind of like, you do the best you can with that.
Let me ask also Francisco and Renee, because you do have a little bit more court of public opinion, perhaps, than those of us at the medical school and wise and healthy aging.
Well, I mean,
Yeah.
so,
go ahead, Renee.
Okay. Go ahead. I think me. I think, yeah. I mean, these are tough. We've given some tough examples here, and every week we have tough examples. I think some of the most wonderful parts about this particular Center of Excellence is their follow-up that's done. That we will have cases, and maybe at this moment in time we can't do anything, but something shifts slightly. Some fact happens. And then we relook at it, and now maybe we're going to take a different approach. So these people do not fall off our radar. once they've been heard, they stay with us. And so while this may not have been the moment in time for that to happen, we all remember this case, and then we'll be follow up on this case. And if there needs to be a shift in how we handled it, then I believe as a group we'll figure that out.
Yeah, so for APS, like I stated earlier, it's self-determination. If the person has the capacity, then what do we do? And when that case is getting ready to be closed, that's why it always goes to the supervisor, and the supervisor can come back and say, hey, maybe this should go to Center of Excellence, because our Center of Excellence is for assisting in those cases that are complex. And like Renee said, for the social worker, that small shift will come with the Center of Excellence, because once it's transferred to the Center of Excellence, then we know there's other team members that are able to assist and provide that case management, whether it's for 1, 2, 3, 4, 5, or 6 months, whatever it may be. Our social workers constantly keep getting cases and cannot keep this case open or follow up with all the services that are needed, and that's where our Center of Excellence comes in, and it's very important, because that's one of the things that we tell our social workers, when you have this complex, challenging case, then let's look at it. And if we've done everything that we possibly can do in terms of referrals on our side in APS, and we still need that that assistance, then we look at the Center of Excellence to provide further assistance and the case management of that case.
If I can
Thank you all.
add, Dr. Mosqueda, sorry.
Please, Fabi, of course.
I think it's a good time to add, following what Renee mentioned, we do have a practice where I follow up 2 weeks post a case presentation, 4 weeks, 6 weeks, and 2 months later. So I check in with the presenter and I make sure everything's okay. If you need further assistance, any further recommendations, if the circumstances have changed, then we invite them back to the Center of Excellence for them to present the case and get further support.
Thanks, Fabi.
So we have another question here that's sort of related, and it is, how does the team use risk assessment while balancing a person's wishes? So at what point does the team weigh safety over a person's wishes?
Anybody want to jump in on that easy question?
I think, Laura, what I can say is every case, every time. I think that's what we do. That is, like the issue of capacity. It's like, do they understand what the risk is that's on the other side of making that choice, that they're expressing that this is what I want? Part of it is me assessing, does that person truly appreciate what that means to them? And then I bring that back to the team, and as a group, that gets discussed broadly. So it's not just my own view on it, it's really the whole team that's looking at it. So I think it's about trusting each other so that we can come to some consensus around, is there too much risk here for us to allow the time to let this percolate a little bit? Do we need to do something big now? Or can we respect that autonomy for a bit and see if this gets less risky? It's the best I can respond.
So my response is safety is a huge concern for me in most of these situations. And what I do really like about our team is we have the cases in advance. We do our research on them, and we bring extra, that means that can be bringing extra information into our meeting. If it's somebody who has a criminal record and that criminal record is significant or meaningful, and I have the ability to get it, then I'm going to share that information. And maybe that changes the opinion on what weighs more heavy, her desire to stay potentially in a dysfunctional relationship and safety concerns about him. So I think we're all kind of looking at, you know, we've Googled, we've Zillowed houses trying to figure out if they're, you know, in imminent foreclosure, you know, positioning, how desperate is this situation? We're always trying to get as much information as we can, and each agency has a different piece to add. So I think that because we do that and we're all trying to get the best information possible for this decision. But from my perspective, I always look at these in a realm of safety. And I may put her desires second.
I think a lot of the other questions are getting into the nitty-gritty of have we tried this or that or this. So I can ask those questions if you would like, or if you want to move on to the next case so we can stay more to the principles.
Yeah, no, I really appreciate that, and I think it shows what a caring audience we have, and we'll I think Talitha will be able to preserve the comments and
Yes.
get any help from you all. So maybe we need like national MDTs where we can have 100 or however many people are on chiming in for ideas. So thank you for that. I do think we'll move on then to the next case example, and I'll just remind my teammates that we have a total of a little less than 15 minutes left, so about 15 minutes. So we'll just want to be efficient with our time here. And I'll just present the next case, and we'll go from there. So this is about a person who is an 83-year-old man whose wife had passed away. He has 2 grandsons. Those are his only living relatives. Both of these grandsons are convicted drug abusers and dealers. And in the past, they both have taken financial advantage. He went to the hospital with a relatively minor stroke, never minor to the person experiencing it, I understand, but he was going to recover pretty well. So he was in a nursing home getting rehabilitation. And while that was happening, one of his grandsons was released from prison, went back to the home where he lived, where both of them lived. And now the older gentleman, Harry, wants to go home from the nursing home and wants to live with his grandson. He's cognitively doing well, but he has a lot of care needs, and not a lot of, kind of this came up a little earlier, into how he could handle like the degree to which he needs help and how to arrange for care. So again, we're going to focusing on a person-centered approach. And I think for this, we'll maybe start with you, Miles, and then we'll let the team engage in dialogue.
Sure. And I'm going to ask Dr. Olson to jump in and chime in with anything you want to add or correct. I just want to add a few more details, and I'll be brief. I know we're running out of time here. I just want to add, so that the clients had almost a dozen APS reports over the years with concerns of various forms of abuse, including self-neglect. There's been several agencies that have made efforts to assist the client with health and safety. Another really important part of this discussion is that the client has very clearly expressed a great deal of love and concern for both his grandsons, and this desire to maintain the relationship with them. And that's, it's just very clear very consistent and clear over the years. That's been his relationship. So after the MDT case discussion, Dr. Olson did the capacity assessment, and the client was ultimately referred to public guardian for conservatorship of his estate only. So that that leaves the client with a lot of decision making ability and authority around his medical care, where he wants to live, and a variety of life decisions. Initially, the advocate helped the client with identifying care facilities that the client wanted to live. The client, Larry was, had stated over the years, I like these facilities. They're really nice. I'd be open to moving there. So the advocate said, oh, well, if that what you want, then I'm happy to help you. And you know, toured facilities and looked into the facilities in terms of the, you know, the cost and the client's ability to pay. However, the client ultimately decided, you know, actually, I want to go back home. I don't want to do this. I want to go back home, and I want to live with my grandson. So I'm gonna stop there and let Dr. Olson jump in if there's anything else you want to add, and I'll pause for other, you know, comments from the panel.
Yeah, this was again one of these cases where it was a little bit like it was right on the cusp of multiple, it could go this way or that way. And it really felt a bit like threading the needle to get at enough ways, like a strategy to get some safety in the system here, this family system, and yet help this gentleman retain as much autonomy as possible. And essentially, in doing the assessment, and I saw him twice because we kept going back trying to figure out what would get that balance right. And I think landing on that guardianship of the money only, the finances, was a way to ensure that his welfare was protected, so that his funds would be used for his care and wouldn't be stolen by his grandson. And if they wanted to have you know, if they were able to have a loving relationship without the financial incentive to it for the grandson, then that was great, and we would support that, and we would help that to foster that. But we also wanted to make sure that his money was used for his care. And the client kind of like agreed with that. He was sort of on board with, okay, that makes sense to me. So now what public guardian is going to do with that and how the court is going to respond to that is another matter. But I wrote as best I could, supporting documentation so that the court would understand the risk that would occur if his finances were not protected.
And
Can I
any other?
quickly just add in one
Okay.
strategy the advocate provides? So this is referencing the previous session around you know, around trauma-informed practices, but you know, sometimes the recommendations can be things that are happening to the client versus with the client. And you know, you know, as Dr. Olson had mentioned, the advocate was really able to work with the client and explain all of the steps of the process in terms of public guardian and potential conservatorship. And so that buy-in was there, where he, you know, he had an understanding and, you know, was able to participate in the process.
Right. And that's an important part of person-centered care. Fabi, I don't know, do you remember who made the referral?
The referral was initially made. Oh, sorry, that's for Fabi. I was initially made by law enforcement.
And so I was just wondering if maybe Fabi is the one who does the intake. Was there anything you needed to do to sort of facilitate a person-centered approach when you got the referral?
What I recall for this case specifically, I think it was important to identify who would be best to deliver any supports or services, which in this case, it was Wise and Healthy Aging. Since the client had history with Wise, we felt as a team that it wouldn't be law enforcement, it would be one of our advocates to do that since it was history. So it was somebody familiar to the client.
And Francisco, for those areas that don't have advocates, because I think we're lucky that we have that, and where even more falls on APS, can you talk a little bit about this person transitioning from nursing home, you know, where there's long-term care ombudsman to home in kind of a risky situation, and the role of APS?
We know that many of the times some of these facilities want to they make APS part of the discharge plan, and that's not supposed to happen. But once the individual's in the home, then we try to work with our other program or other contractors in terms of getting assistance for in-home care or any other ADLs, IEDLs, whether it's also going to be nutrition services, and then determining based on the need what are the next steps. For example, on the service plan, if we need to get let's say for example in-home, like I was saying, in-home care, then we'll work with our Department of Social Services to try to expedite those applications, to try to get a social worker out there as soon as possible to do the evaluation. Because sometimes individuals can call DPSS and it just takes a little bit longer for DPSS to take the application. So on some of these cases, we can reach out directly to our sister department, DPSS, and get an application started right away.
Thank you. I'm gonna go off, like slightly off this case for just a minute to ask Renee Rose, just because we only have a couple minutes left. But sometimes I think there's a sense for particularly like law enforcement and prosecutors, the idea of person-centeredness can be really hard for you to practice because it can be in conflict also with your role. Do you have any thoughts about that?
Well, I think particularly with this population, we have to have their cooperation. So we do look at things in a more person-centered approach, because if they don't cooperate, we don't necessarily oftentimes have a prosecution. And so a lot of that is building a relationship and finding out what the issue is in the home. So if the issue is in the home that, say, some violence occurred and the issue is mental health and drug addiction, then we want to, knowing full well that that child will go, 57-year-old son that we call children here, that child will go back into the parent's home. We may want to divert that person out of the criminal justice system into treatment and hold a case over their head or diversion or whatever we're going to do, and monitor that treatment and give them another place to live with treatment and job skills. And we want to try and help fix the problem so that they don't all coalesce back together again, to the one place they can go home to. So I think that is a person-centered approach, in that that's really what the parent wants. They want their child to be better. And they have no way of accomplishing that. And so that takes over, that, and ultimately that makes them safer. So if we can fix that problem and they do come back to the home, then we've created a safer environment. So I may have called person-centered, too, but it's right up there with needing to not traumatize this population, help them get where they want to go, but still, we're still doing significant things that tend to rock people's world.
Laura, if I may say, just in closing on this case, one of the comments I heard from Harry directly out of his mouth in describing his relationship with his grandson, he said, "I called the cops on him once before, and darn straight I would do it again." And that is part of what it was, like a really strong indicator to me that, okay, this could work this way, as long as his money was buttoned up, that he had that strength internally. So it gave us confidence.
Thank you. And Talitha, I'm going to wrap up unless you have one or two questions you think we ought to address.
I don't think we have any questions, just one comment that mentioned something about relationship building. And I think this way you're describing this person-centered care is highly relational. It just strikes me that it's relationship building in every direction between your team members and the agencies, and with the clients and their family, and maybe even perpetrators. So it's really interesting. I don't know if you have any thoughts on that as you close.
I'll try, and I do want to be careful that we don't label everything with this anosognosia, that because a lot of us lack insight for a whole variety of reasons, and sometimes there's a specific neurologic disease as well. So we just need to be careful in terms of kind of medicalizing and labeling some of these things. And clearly relationships are the key, community is the key, the way we work together, and all of our connections, I think, are the key as well. And the other important piece, of course, is relationships take time. and people have histories with law enforcement or physicians or whatever. So whenever we walk into a situation, it's back to what Joy talked about, right? What are their prior either good experiences or traumas, and we have to be aware of that. Oftentimes we're in situations where there doesn't seem to be time to develop a relationship, but oftentimes I think we need to make the time and value how important that is in order to do the best good that we possibly can. I think that what people heard today was kind of a real life example of the sausage making, of all the difficulty, and again, that we don't have it right, but we're really trying hard to practice this. We're really trying hard to understand our clients' goals and wishes, to elicit them, to follow them to the very best of our ability in order to help them reach the highest level that they can and want to reach. And we acknowledge this isn't easy, but we hope that this gives you a taste of some approaches that can be used, the importance of relying on our team members to do that. And I'd love to learn from all of you. My email, it's my name is up there, laura.mosqueda, and if you just add an @med.usc.edu, you can find me. So feel free to send an email if you have other thoughts, questions, or comments. I just want to thank Andy and Talitha and Shelley and the whole team that that allowed us to have this time with you. We really appreciate it, and we're grateful for the work that the people who are attending this do every day on behalf of the people we serve.
Thank you so much, Dr. Mosqueda, and everyone on the panel. We really appreciate your contributions to the summit and your insights around person-centered practices. We are going to pause for a short break before we move into our next session. So we'll see you back here in about 5 minutes.